Here's a point.
The course point or I'm an idiot. Canvas. Thank you. I could not think of it to save my life. Said that it was over week 10. The quiz was gonna be over week 10, which was ear and eye. I mean, I still obviously we still should know all that too. But I was just saying that's what I like looked over as well. But I just want to let you know that.
I'll go back and look.
Okay, thank you.
This week is the musculoskeletal lecture, right?
I was just a little arrogant for me.
I was like, there's something different about her.
Right? How about you?
I think so.
I didn't know that. Yeah.
Okay, so we're going to talk about the musculoskeletal disorders today. I happen to really love this musculoskeletal disorders. Most of my experience is in med-surg orthopedics. I worked at Baptist, St. Joe, and I was a clinical nurse specialist for orthopedics for pediatrics at Shriners. So lots of things we think about with musculoskeletal. We think about bones and muscles, but then also thinking about tendons and ligaments, and then thinking about when we have an injury to one of those areas. Of course, it's inside the tissue, and there's only so much space in there. So if we start getting leakage of blood or fluid or inflammation that brings extra fluid to that area, we have the risk of impinging and preventing blood area, impinging of nerves that bring movement and sensation. So assessment of those types of things are extremely important in patients, not only immediately after they have an injury or have surgery, but continuing throughout their stay. So we're going to be looking for anything that shows not only some type of infection, but also lack of blood flow, lack of nerve innervation that gives us movement and sensation. So testing for all of those types of things. Okay, so the first kind of disorder to talk about is, yes.
Are we going to go over the quiz today?
No, it's in the PowerPoint. So when we go through the PowerPoint, it has all the answers in there. Okay. So osteoporosis is a disorder that is a metabolic disorder. So what we mean is with a metabolic disorder, that's when we pull things up and break things down, and there's a disruption in that. So osteoporosis is chronic, meaning that we don't wake up overnight and have osteoporosis. It's progressive. It takes a while for it to happen. And one of the most interesting things is that our peak bone mass is really when we're in our 20s. So that's the time when we should be storing up things like calcium and building up big, strong bones, because when we start turning into 30s, then we start having more bone breakdown happening. And there are things that go on that can increase that rate of bone breaking down. So we need to know those, not as an older person when those things are happening, but as a younger person to know how to prevent those things, okay? So it's caused by bone loss, which decreases the density. So our bones are porous, meaning that there are small holes in them, and bones aren't hollow. They contain blood vessels and nerves, and our bone that creates, sorry, I'm having a hot flash up here, that helps to create our blood cells. So having good, strong, healthy bones can also help us to have good, strong, healthy bone marrow, where we produce things like red blood cells, white blood cells, and platelets. And if we have increasing bone breakdown, then we don't have bones that are that strong. And so we're at increased risk of fractures, increased risk of brittle bones. And when we think of fractures, many times we think of the long bones like our arms and legs, but also thinking about our spine and having fractures in our spine. The weaker the bones get, the more likely we are to have fractures that are called pathological fractures or spontaneous fractures. So you and I may be able to walk and step off a curb funny and not have any problem, but someone else who has very weak bones could step off of a curb off balance and fracture a part of their spine or their leg. And so those things can happen with fracture and injury that shouldn't normally cause an injury. It's referred to as the silent disease, of course, and a lot of things that we think of as chronic and progressive are. And I think of this kind of equating to hypertension. Many times we don't feel that we have a disease process until it gets really bad. So knowing how to prevent it from even starting is important. Okay? The spine, the hip, the wrist are the most often at risk. And we think about if we were to fall or have an injury, the things that would most be impacted may be our wrist, because we would fall and try to catch ourselves. It could be the hip, especially if our leg is twisted or we land on our side. And then the spine as well, because it holds up all of our muscles and other bones in our body. It's the most part of our body that should be supporting our weight, really. Another term that we think about with osteoporosis is, what do we call it if we don't have osteoporosis yet, because we said it's progressive, but it's beginning to happen? And that's what's called osteopenia. Anything with penia, meaning small, kind of like neutropenia, those kind of things, a small amount. And this is when we have the beginning conditions where the bone density is lower than normal, but it hasn't gotten to the extent of osteoporosis yet. And so much like we think about someone that may be pre-diabetic, they're not in that disease state yet, but this is a warning sign that says we're progressing to this point, and what kind of things can we do to maintain bone health the way that it is? So testing patients for osteoporosis, we want to make sure that we're not only saying, are they osteoporotic or not, but to the point where it's a warning sign so that we can start to help them to maintain that bone health instead of progressing. All right, so risk factors, older age in both genders. Okay, again, if it's progressive, the older we get, the more likely that damage has progressed and kind of accumulated over time. Parental history, so history of osteoporosis, particularly in the mother. Some of the things that can increase osteoporosis have to do with estrogen, and so hormones. If we are lacking in estrogen, and as we get older, our estrogen levels decrease, that increases our rate as well. So hormone levels could have something to do with familial history as well. History of a low trauma fracture. So is there a sign that someone at an earlier age, it says after age 50, so in this beginning point where we think we still should have bones that are pretty strong and not break easily, if there's someone that already has broken bones from things that really shouldn't cause broken bones, then that's a sign that they may already be very progressed in this disorder. Low body weight and thin build. And so someone that has kind of genetically a small bone mass, most common in really about patients that may be of Caucasian or Asian descent who have very small, fragile bones. And the smaller they are, the more likely they are to deteriorate. Chronic low calcium and or vitamin D intake, and we'll kind of talk how those things go together. So if we're not getting enough of those important things, that lower calcium, take calcium into the intestines with the vitamin D, then we're not going to be able to store those up for big healthy bones. And that makes us starting to have deteriorating bones at an early age. So those are things that we really can have some kind of control over. We can change that. Postmenopausal, and so estrogen and androgen. Androgen we usually think of as being a male hormone. So like we said, as people age, male or female, they have an increased risk. It's most common in females because we think that females, we think of androgen, we think of testosterone. Females have a small proportion of testosterone compared to men, but females have androgen and testosterone in increasing levels. So women are more at risk, but men also can have osteoporosis. Current smoker, either an active smoker or a passive smoker, so someone that's in their environment and they have secondhand smoke, continuous exposure. Okay? We think that smoke has to do with blood flow that gets to the area as well, that helps to bring those nutrients that bones need. You know, if we think about calcium and vitamin D, it's transported in the blood system to the bones. High alcohol intake, being 3 or more drinks per day. How many drinks do you think that is okay, or the recommended kind of amount for a female to have? 1 per day. And so when they consider high, they're really thinking about 3 or more, or really above that normal amount. And then lack of physical exercise. Again, we think about how important muscles are in support bones and being able to protect against that impact of injury. And if we don't have strong bones, we don't have good blood flow that gets to the area, good nutrients that are coming in, then the bones are more at risk of having fractures. Okay. So medications increase the risk of osteoporosis. What medications can cause us to have weak or brittle bones? And we said that was because the osteoclast, the breaking down of the bones, that part is increased more than the building up. So some medications can prevent the building of bones, so slowing that part down, causing those bones to become more porous. Medications would be glucocorticoids, so it has steroids. And so one of the important reasons we talk about steroids, taking it the smallest amount of medication for the shortest amount of time. And we've said there are many other reasons that steroids can cause problems, but they're important anti-inflammatories, so they are beneficial, but short amount of time. So we think about someone who may be taking them more frequently, someone with an autoimmune process, maybe someone with Crohn's or ulcerative colitis, someone that is taking medications for maybe a respiratory problem, if they have recurrent respiratory infections. So anybody that's taking corticosteroids, particularly reoccurrent, has an increased risk. Heparin, so blood thinner, anticoagulant medication, used to prevent abnormal blood clotting, of course. So about people who are taking medication to prevent blood clotting, in particular heparin, can cause that to happen as well. Certain anti-seizure medications, so things like Dilantin, phenytoin, phenobarbital, all of those can interfere with the building up of bones. And then aromatase inhibitors, those medications that are for breast cancer, to either slow the progression of tumor growth or to destroy tumor growth. Again, those interfere with some of the building processes, in particular interfere with the building process of those tumors of increasing, but they also can affect bone building as well. Kind of like a lot of medications, pros and cons, take it for the shortest amount of time period. All right, so how do we care for someone with osteoporosis? Many times if a patient comes in, their complaint isn't going to be, I think I have osteoporosis. It may be that they have pain that could indicate a fracture, okay? So it is recommended that women 65 and older have a screening for osteoporosis, but if they have a family history or they have other characteristics, it could be that they have them screened earlier. And we'll kind of talk about how they do that screening. But some of the most common symptoms, the first is back pain. And we said that those spinal injuries, which most likely present as back pain, could be a small fracture that's happened really from impact. And when we think that, it's the impact of our own body weight. So maybe if we've slipped and caught ourselves or step off a curb, the wrong way or something like that, where you and I may just have maybe a little sore muscle or something like that, even if we caught ourselves, somebody else could have a fracture in part of the spine. So back pain caused by a fracture or a collapsed vertebrae, loss of height over time. So we can see this kyphosis that's happening here. And that is part of the spine that's deteriorating, and it can't support the weight of the body anymore. So in order for a people to have balance, then part of that spine becomes curved to release some of that pressure of the weight, but also to maintain that center of balance in the body, that stooped posture, and bones that break much more easily than expected, particularly if someone has a fracture, like we said, in one of those areas, like the femur or the wrist or the spine, or they've had a fracture and it doesn't heal properly. So some things that we have to think about with our patients, the first one being a knowledge deficit. So many times, like we said, people don't know they have osteoporosis, or they don't know they're at risk of osteoporosis. And then how do we prevent it? If they have it, how do we prevent the bone breaking down from getting worse? So how do we preserve the function they have? Lots of things to learn about how they care for themselves. Pain, so they may have acute pain related to a fracture, risk for constipation, and that has to do with some of the medications that they may be taking. We traditionally don't recommend that patients take calcium. Calcium isn't a great thing to have too much of in the body. Some of the things that it can cause can be things like constipation, but it can also be things like depression, kidney stones, all those types of things. Yes.
So then they won't be getting calcium supplements, or just an excess of calcium?
Right. We give an excess, and we think about eating things with calcium. We're truly not going to overeat things with calcium. We think about that, but we only can get so much of that from foods and things like that. So for you and I that have normal building up and breaking down, those things are beneficial and important. But someone else who are at risk or who has beginning osteoporosis may need something that's going to either help slow down that breaking down if they already have osteoporosis, or something that is going to bring in more of that bone restoration. And then risk for injury. So we know that if they have osteoporosis, even osteopenia, they are more at risk of having an injury or a fall. So how do we prevent falls, and thinking about those things? Making sure if someone's supposed to use a cane for balance, that they do that. Having someone maybe assess their home environment, like home health, so to make sure they don't have cords everywhere and throw rugs and all those kind of things fall over, handrails in the shower, all those kinds of things. So how does nutrition, we said we talked about calcium, but there are other things that are in the things that we eat and drink that could actually prevent calcium from being absorbed completely. So it's not just the intake of caffeine in the diet can cause calcium loss in the urine. So it can cause us to not get calcium stored in the bones properly. So not too much caffeine. Diets lacking in calcium and vitamin D stimulate the release of calcium from the bone. What happens is if we don't take in enough calcium, calcium's not just for teeth, it's also for muscle function, and one of those being the cardiac muscle, right? So if we don't have enough that's circulating in the blood system, our body pulls it from the bones, and that causes weakened bones. So we need a good balance of calcium, and then vitamin D helps to absorb that calcium from the small intestine and take it where it needs to go. So both of those are important. Activated vitamin D is needed for calcium uptake, and so vitamin D, we get that from the sun. So is it someone who doesn't get outside very much, maybe someone that's bedbound or homebound, and they're not getting a lot of vitamin D? And then our multivitamins have vitamin D. Also, a lot of our foods are fortified with vitamin D, things like milk and orange juice and some grains like breads and things like that. Patients who are homebound, we said, not exposed to sunlight at an increased risk. Protein deficiency also reduces bone density, as well as reduces muscle mass, right? If we don't have good muscle mass, our bones are at an increased risk of fracture as well. And we also need protein for bone healing and muscle healing if we have an injury. And then excessive alcohol and tobacco use increase bone loss. It says they don't quite know the mechanism. Again, part of that could be the way our liver metabolizes, the way that our blood vessels function to get nutrients to the bone. So it's really multifactorial. So what kind of things have calcium, or the best sources of calcium? We think about usually things like milk and yogurt and cheese, which do, but there are other things, especially if someone doesn't eat dairy or doesn't take enough dairy. There are other foods that have great sources of calcium. So things like fish, things like sardines and salmon, seeds, nuts, of course our citrus fruits, green leafy vegetables like broccoli. Those are also really good sources of calcium. Okay. Other things that we need calcium for. Yes.
Sorry, so what was the answer on the quiz?
Salmon.
Salmon? Okay.
Yes.
Because I know there was orange juice on there too, so I just want to make sure I get it right.
Building strong bones and teeth. So calcium is important for blood clotting. It's important for cardiac function, other muscle function, nerve function, sending muscles through the nerves to the brain and back to the muscles, releasing hormones, building onto hormones, as well as proteins that carry hormones, and then keeping a normal heart rate. So making sure our cardiac function is important. And we said that what our body does is it needs to preserve that cardiac function. So if we're not taking calcium or that vitamin D to carry that calcium, then our body will pull it from the bones and teeth to support our cardiac function. Yes.
So for calcium channel blockers, if calcium keeps a heartbeat, why block it?
We're not blocking all of them. If we blocked all of them, if we completely blocked our calcium channels, we would die.
Okay.
So it's just intermittently blocking some of those.
Okay.
Yes. Okay. So how do we stay healthy? How do we teach patients to promote health, maintain good bone health? We said that peak bone mass is achieved by about 30. So many times if we decided we were going to go out and educate 20-year-olds about bone health, of course they would think, why are you telling me this? Because we think about bone health and problems with bones as being an old person's disease. And truly by the time it gets to that point, then we've already lost a lot of that bone mass. We can't rebuild that bone mass. Okay? So building strong bone as a young person is the best defense. So a healthy, well-rounded diet, patient education is important. So all of those things we talked about, how to modify risk factors, and some of those things being alcohol, smoking, diet, exercise, increasing calcium in the diet, reading food labels. So how do I know how much calcium's in food? How do I know what has vitamin D? All of that's very confusing. Helping people to understand exactly what some of those foods are. So if we simply told patients, get more calcium, that may be very confusing. But if we can list or even consult a dietitian to say, these are what these foods are, that makes that connection much more manageable for someone. Again, and teaching them to read food labels as well. Getting adequate sun exposure, even in cloudy or days that are in the winter, we're still getting sun exposure. Limiting carbonated beverages, caffeine, importance of exercise to strengthen those bones and muscles. And then discuss with postmenopausal women whether or not to take estrogen. And so we said that one of the things that can happen as our estrogen decreases is our bone mass starts decreasing. So one of the things that is kind of a plus side to taking hormone replacement therapy at menopause is to decrease the risk of osteoporosis. Now, there are other risk factors that go along with that, increasing risk of stroke or heart attack, increased risk of breast cancer. So increasing risk with hormone replacement therapy like estrogen. But one of the things that it does help to preserve is bone health. Now, we wouldn't simply give it to someone to make sure that they don't have osteoporosis. There's too many risk factors involved. But that is an important factor if someone is trying to decide if they are going to take that hormone replacement therapy. So we wouldn't simply give it to someone that's not menopausal or something like that. That wouldn't really be an option, is to just increase our estrogen. So what do we assess? We're going to do a fall risk assessment. We said that if someone has weakened bones, brittle bones, then they are more likely to have an injury from some type of a trauma, even something that shouldn't cause problems for you and I. So a fall risk assessment, we're going to do that on every patient, every admission in the hospital. We do it every shift of assessing who's at risk for falls. Patients may state that they've gotten shorter, right? So when they come in to their doctor's appointments, they may measure how tall they are, or they may, say that they've gotten shorter. The physician may also assess them for that curvature of the spine, and those are signs we think about really equate to aging, but they also equate to kind of weakened bone health. So taking height and weight is important. They may have back pain. Okay, as well as witnessing that kind of a deformity or curvature of the spine, assessing for things like tenderness and edema, and restricted movement. So if something hurts, we tend not to do it or move it. So if someone's complaining of an injury, they've changed the way that they're walking, they change their gait, things like that, they become more unsteady. It could really be that they don't have the support of the spine like they should. It could be assessing body image or self-concept. Again, it makes physical changes on the body, and can cause people who are in pain or have decreased mobility to kind of isolate and not go out and do as many things if they're in pain or they're at risk of falling, they're afraid of falling. So assessing for those things and helping to modify their environment to make it safer. So we said things like handrails, using an device like a cane, making sure that they have non-slip shoes on, making sure that they don't have throw rugs on the floor or cords or things like that could make their environment safer. And then teaching patients to be extremely cautious about things that could lead to a fall. So that they understand that they're at an increased risk of more injury that may be difficult to heal. We said that protein and calcium and all those things are important for bones and muscles, and that could lead to fracture, but it also could prevent them from healing properly. So what kind of diagnostic testing can we do to look at bone health, to see how their bones are developed? So some of the things we can do is look at some blood work, look at labs. We can assess the levels of calcium in the blood, vitamin D, phosphorus. Phosphorus and calcium have an inverse relationship. So if we look at our labs and someone has an increased level of phosphorus, that helps to pull calcium out of the body. So increasing phosphorus, we also have decrease in calcium. We can do x-ray. So especially if someone has an injury, they have pain in their spine, pain in their hip, they're going to do an x-ray to see if there truly is a fracture in that area. Right? It says that decreasing bone density, we can only really see anything about bone density on an x-ray after 25 to 40% of bone loss has occurred. So it's not a great screening tool for osteoporosis, but if we suspect there may be a fracture, they're going to do. Okay? But to test bone density, they're going to do something called a DEXA scan. And a DEXA scan, it's a low-dose x-ray, but it's particularly looking at the density of bones, the porousness of bones. They're looking at the width of the bone, the bone compared to, number one, what the average bone of someone who is that height and weight and age should be. But also, if we have a baseline of this and we go back and get another one, we can compare to see if there's been any changes from the previous time. So they usually look at the hip, the hand, or the foot for signs of that mineral loss and bone thinning. And so we'll kind of look at what some of those results look like. So this is the results of a bone density, or it's called a DEXA scan. Yes.
So will in osteoporosis, will calcium be low and vitamin D be low and then phosphorus be high?
Yeah, it usually,
Okay.
yes. So we can look, and what they're going to do is they're going to measure certain areas on the body that have particularly increased showing of that osteoporosis. So things like the neck of the femur, they're going to measure, as well as any changes in the head of the. They're going to look at the spine. They're going to look at, is it in alignment? Is there any decreasing areas of size that could indicate that the bones have been fractured or there's decreasing bone density in that? And then they're going to compare that to the norm for that patient, for the norm, and that patient from previous tests that they may have had. So your bone density scoring, or what's called a T-score, can show if there's any changes and if they are at risk of osteoporosis. So if they have osteoporosis, they have osteopenia, that low bone mass, or they have normal bone density. And so we also know that even if we have normal bone density, if we're on this side, then we're getting really close to that. So talking about some things either at this point that can prevent bone loss, prevent continuing bone loss, and then preserving the bone loss that they already, the bone density they already have. We don't want it to get worse. So those T-scores are measured. It's a statistical measure that reflects the difference between your bone density and the average bone density. So someone that's healthy of that sex, what it should look like. So anything over 2.5, and it's in negative scores. So 0, of course, down in here would be normal, and these are decreasing amounts of bone density. So 2.4 to 4, 2.5 or greater indicates osteoporosis. So what do we do if someone is diagnosed? Okay, so treatment recommendations are based on that T number, that estimated risk of breaking a bone. So how at risk are they of that? We can't rebuild bone, so we can't increase that density, but we can prevent further bone breakdown. If the risk isn't high, treatment may focus just on those modifying risk factors, right? So caffeinated beverages and alcohol, smoking, increasing calcium and vitamin D, all those things to prevent it. But if they already have that osteopenia going into the osteoporosis, then they may need something more aggressive, something tailored toward lifestyle and medication to help preserve what they have. They can also do a test called a fracture assessment risk score, and it's kind of like a fall risk or a Braden skin scale, some of those things that are looking at risk factors and what's your total number on those risk factors. And I kind of linked one here, but this is what it is. And their questionnaire, it's a questionnaire that looks at things like your age, your lifestyle habits, any history of osteoporosis, history of menopause, are they taking estrogen, all those kind of things that we think about as risk factors. And the more risk factors, of course, the more likely they are to have a fracture if they were to have some type of injury. Okay? So look at that risk, talking about the bones, but also looking at, with that questionnaire that they ask, they're looking at what is the 10-year probability of having a fracture. So we're looking forward at if we are continuing to do the habits we do, modifiable and non-modifiable, we said, what is our bone density going to look like in the future if we don't make changes? And so it can show if they are predicted to have major osteoporosis, hip fractures, osteopenia. And so again, we can look at not only what's going on now with a bone density, but the prediction of things in the future. So that can be done at any age. So when we think about medications, we can think about medications to prevent osteoporosis and medications to treat osteoporosis, okay? And when we think about treating, we think about taking medication to preserve bone loss, not rebuilding the bones we've already lost, okay? So to prevent it, we can do things that are over the counter. And so people think if medications are over the counter that they're not harmful. So again, educating patients that taking it as prescribed, not taking lots and lots of it, because there can be some bad side effects. So Oscal is a calcium vitamin D supplement, okay? And it's taken under the direction of a healthcare provider. Again, we want to educate them about things that are even over the counter, and having regular labs to avoid increasing calcium, that hyperkalemia. So continuing to follow up with them about taking that and getting lab work done as well. So some of the things that can happen if we have elevated calcium, so greater than 10.5, right? Stones, so kidney stones, gallstones, bone pain, right? Abdominal pain, nausea, vomiting, polyuria, so increasing urination. Our body tries to get rid of things that we take in that we don't need. And too much of that would be, our kidneys would be working really, really hard. And then it can even cause some psychiatric issues, things like anxiety, depression, insomnia, leading all the way to coma. So especially if we're talking about the older person who maybe their kidneys aren't able to work overtime for a long period of time, they could really build up calcium. So what other medications are used for prevention and treatment? Biphosphonates are medications that are widely used for prevention, but also for treatment, okay? So what they do is they slow down that breaking down of the bone, okay? And that removal of the bone, those nutrients being pulled out and getting rid of from the body. So if someone is in that osteoporosis area and we're trying to prevent osteoporosis, they may go ahead and start these. Okay? But we know that if we can just use lifestyle factors and not do these things, then they're going to do that first. Okay? The more advanced it is, the more likely they are to start medications. Some brand names of biphosphonates, things like Fosamax. We said they reduce the risk of fractures because they slow down that bone breaking down. They would decrease the loss of height, again, preserving the spine. That's so important. And it's available as a pill. Okay. Other medications like Actonel, very similar, both biphosphonates, and they reduce the risk, again, of fractures because they reduce that amount of bone breaking down. Okay. And there are pills, they take them once a day. There's also ways that they can take those depending on the risk, once a week. Some of them are prescribed once a month. Again, varying dosages and depending on really how advanced their disease process is. Important for biphosphonates, and we give these in the hospital a lot because people take them at home, is that we need to sit up for at least 30 minutes, some of them say an hour, after taking them, because we don't want those to stay in the esophagus and erode and cause damage to the esophagus. So take them, they said, first thing in the morning. We don't want them to take them at bed and lay down. On an empty stomach, full glass of water, and they need to wait a half an hour to an hour, depending on what type they take, before lying down. Okay, instructions help to ensure the drug will be absorbed, reduce the risk of that acid reflux, again, that can cause damage to the esophagus. Other medications are kind of similar to estrogen. We don't want patients to take estrogen simply for preventing bone loss. There's too many side effects. If they are taking it for menopausal symptoms, then this is a benefit of it. So certain medications known as selective estrogen receptor modulators, again, help us to utilize the estrogen more effectively. So they produce some estrogen-like effects without the side effects. Medications include things like ralofexine, which is Avista. They provide protection against postmenopausal bone loss. So similarly to working on those receptors as estrogen does, it says they also can have some benefit to decreasing the risk of breast cancer in women who are high risk. So used for other reasons, And they're not recommended for premenopausal women. Again, we don't want to cause any issues with hormone production that our body normally does. It could cause too many adverse side effects in someone who is not at the postmenopausal age for estrogen. This is kind of helping to try to preserve that estrogen loss that we start to have in that age period. Right. So estrogen is not recommended for the treatment of prevention of osteoporosis. We said too many side effects. However, some women who are postmenopausal do take estrogen supplements. If they take estrogen, they don't need to take additional drugs to prevent bone loss. So that should be beneficial to prevent bone loss at that point. Okay, we're still going to work on lifestyle factors. Risk of estrogen. They can increase things like stroke, blood clots. So there are adverse effects of taking estrogen. Therefore, again, we don't want to give estrogen supplements to people who are premenopausal. Too many problems can happen. Maybe appropriate treatment for people, prevention of osteoporosis in younger people only if those patients have ovaries, they're not making estrogen. So again, that's the whole point of, we're not trying to double up on the estrogen. We're trying to maintain our level of estrogen to prevent some of these bone breaking down. Okay. Questions? Okay. Yeah.
What if men, would they take in the androgen instead?
Not usually. That can increase the risk of things like prostate cancer and some other types of cancer. They would probably look at biphosphonates.
Okay.
Yeah.
For the calcium supplements?
Yeah.
Okay.
Yeah. So let's go ahead and take our switch gears talking about strains, sprains, fractures.
What can you do?
Like a lot of breaks and then like 20 like fractures and stuff in childhood, does that cause them to have an increased risk of osteoporosis?
It doesn't cause an increased risk,
Okay.
not at all, but it could be an indicator that maybe going on with their bone strength or something like that.
Okay.
So they might be assessed if it was, especially if it was just fractures that should normally occur. But if they were in like accidents and had fractures and things, it shouldn't have been affected.
Okay. Thank you.
You're welcome.
On Canvas, on the modules or whatever. So the next quiz that we have on Friday, next Friday, it says it's over 11 and 12. So will it just be over 12 since we did 11 today?
I'll go back and look at it. I'll change it and go back and look at it.
Okay.
Yeah.
Thank you.
Thank you for letting me know.
I put them all too. I was like,
I was like, since it's a medication, and it's the calcium and it's the substance. But in all fairness, I didn't study beyond.
Yeah, I studied
And
that
I
in a year.
studied that in a year.
I only did that, I went to Musculoskeletal because Barnum does it that way. And then I went to
Yeah, that's why.
study and so. Oh, I
the other thing said, something said to take calcium.
It doesn't affect your rate.
You want to,
Change.
every time you want to go to the
Stand up or stand.
So, medication was that you want to stand there goes to sit up.
Yes.
Gonna get osteoporosis. Is that what you're gonna do?
These on daily.
My grandma does too, but she's also has kyphosis and scoliosis, and she also is on prednisone for her gout, her what is it called? Rheumatoid. She has RA, so she's just a walking, bless her heart. She has to get a shoulder replacement.
My grandma's
That's gonna be
had her
rough.
shoulder replaced. That's it.
Oh my
2
goodness,
weeks
I'll have
after.
my grandma call your grandma.
My grandma was just telling me like.
Yeah, she's like,
That's her.
the thing is, my grandma, her wrist, got it fixed because they ripped it, but then the bones aren't healing right. So then she just had surgery last year, and now she's gonna have it again. And so I'm just like, well, I said, Mimi, you need to sue. You need to sue.
Yeah, my grandma heard cartilage or whatever was just going.
Because it says week 10. Last time I checked, week 11 is right now. So that's why I studied, I literally went through and studied the rest of the neuro, and then look at the eyes and ears.
I looked at the
Because
eyes, it said because I was like, well, maybe she might have that in it. And I was like, I'm glad I looked at the.
I was so mad.
I did without looking at it. Glance. I was like, skinny through it. And I was like,
Me too, that's the only thing I
That's
did.
the only thing I remembered. I was like,
Literally, because I didn't study this. So I did that ATI last night and I was like, thank the Lord.
Sarah,
Because last night
I'm
I'm still
going
like
to
in my
help you
brain.
reach your goal.
I know, I got an email right
Really?
in
Yes.
class. I was
Are you
like,
serious?
I will help you.
Listen, I'm sorry. I needed emails and I was like,
The only thing I hate though is I'm so sketchy of putting my debit card on PayPal or anything like that. It really creeps
Yeah, I don't
me
like that
out
either.
because I'm like, someone could just hack this and start spending
well, in
everything.
Venmo, it's like, I have a Venmo account, but I haven't verified it because it says to put in your social security card or your. Mine
Does
doesn't
it
ask
really?
me that.
I
Yeah.
don't know.
Oh,
I don't have
yeah.
any.
And I'm like, absolutely not. It says something like.
I just got Apple Pay.
And it says me only.
Because my
I got
coworkers were
Apple Pay.
like,
Sarah Joe, I'm just gonna do the 50. It's nothing. It's the lowest one they have, so
You can intern them out.
that's okay. I'll just do this one.
listen, I didn't expect any of y'all.
it asked for your.
Wait, what did you with your passport? Driver's license?
I'm gonna help her-
ID, or
I'm
your
reaching
social
my
security
goal.
number,
I'm
or
gonna
what
help
do you
her
do?
reach her
I'm
goal.
doing that. Absolutely not.
I'm
I see you want to. Because apparently reach our goal, we get something
$30.
I know for
for
ours,
extra.
whoever is the highest guy and girl, he's gonna buy a new bowling ball.
Yeah, we can. You know what would be cool if she would be like, if you don't get the highest one, she's
You're gonna get a new bowling
No,
ball.
but how funny would that be?
no, I would take it.
ball.
I dare you. Well, I would do it.
I dare you.
Oh my gosh, I have my bowling stuff downstairs. I got it out the other day. And
It's protected
I
by.
was looking at it and I cleaned them off.
It
And I
better
think I
be.
miss it.
Yeah.
I miss it a lot.
I need to.
I think bowling's so much fun. That's
I
probably why
think it
chose
is.
And it's the most
not that
relaxed.
stressful either.
That's
Like you don't have to look
You.
if somebody else is unless you're doing, yeah, the baker, like this.
Expiration
The baker shirt.
It's the most individualized sport.
And you don't have to long do your own thing.
That's why I like track.
Softball is.
Why do I need to put?
Except for I have to run and literally get so anxious.
Yeah.
So anxious before my races that I have to go to the bathroom like 7 times. And I just like.
I can't take all my pants and stuff off, and I'm like, I can't.
And I don't want to take my pants off, but you have to. And I get down the blocks and I can't even like hold myself up because I'm shaking so much.
This is really this.
And the girl next to me is like, what the fuck is wrong with you? Because like, when I hit it, it's so anxious, and then the gun goes off and that makes me.
I'm not going to class talk. I'm just going to my car to get the water.
I feel like I've got faster.
I just contributed to your goal.
You should see all.
I want to contribute.
Everyone contributes to
I'm a
Sarah's
president.
Everybody out there.
What is it on?
It's on each.
Girl, have you ever done it?
I don't know what that is.
Listen, why doesn't your sport make you?
Yeah. Every sport you have to do it. Yes, you have to do it, Madeline. Yes. When? He sent out
I don't even know
emails
how much money you need.
like text messages.
You have to have like 20 emails.
Yeah. I didn't do 20 minutes. I did 10. I said mom, dad, cousin, brother, sister.
I did that already.
Listen.
Oh,
Look at this. That's all
We did too.
osteoporosis. One whole box. It's a big one.
I have like 6 stars for it.
Basically, let me just help you.
Each box is individualized for one.
We know you're struggling, so.
But, you know, I guess 4 is good too. So I will show you what I usually do is this and then write a summary. So I did, okay, so I do this where I write down like medication, the things in each boxes, and then I just.
I like to take notes in here and I'll go back and add more notes. Like,
Oh, yeah, I'll do these like
Playtime.
Yeah, this is so dumb. You would think something would be like, oh yeah, folders. Things can fall out of folders, but oh no, let's not put a little strap here. Let's just let them all fall out. So then someone looks like a complete idiot. Thank goodness for the person who invented fold. Oh, okay.
I don't even know.
I do. Sometimes
I think you need to
I need to
take
have the email of every like major government president whatsoever. I need to have the, actually just skip the email. I need their direct phone numbers. Look at a banana. It's supposed to be reading a banana.
I don't know how to be hot or cold.
Well, it just depends on the mood outside, because I like cold drinks, but if you want it like in the middle of the day, I do iced.
Okay.
But it's good either way. I chug my drinks, so it doesn't matter what I get. I know.
Okay, so let's go ahead and start back. We're talking about the difference between strains and sprains. So strains really caused by twisting or pulling a muscle or tendon. We many times think about strains as something chronic. So if we are overused or repetitive motion, but it can also happen from lifting something too heavy or from overstretching our muscle. So if someone happens to get off balance and lean and they use muscles that usually aren't used for things like that, that strain can happen. Symptoms usually are pain in the muscle spasms, muscle weakness. We tend to think about strains as things that happen in our back, but they can also happen in other muscles. And then sprains being something that we think about more acute. So it's not chronic overuse or repetitive motion, but it is stretching or even a tearing of a ligament. And so it can happen frequently with sports or recreational activities. And it usually occurs and causes not only pain, swelling and bruising and edema. So we think about sprains and being areas of the joints, things about wrists and ankles, and again, accompanying bruising and edema, where we don't usually see that in strains. It's more of a pulling or aching of muscle. Yes.
And the strains is the chronic?
Yes. Yes. So how do we treat those? So strains, again, of our muscles and kind of a pulling of the muscle, heat and cold application. So many times that physicians will recommend that we alternate heat and cold for pain and then heat being for relaxation of muscles. Exercise with limited activity. So we still want to do those stretching and movements to help with preventing those muscle spasms. Could be muscle relaxers. To help relax those spasms of the muscle. And then if we have a tear or rupture of a muscle or tendon, they may even need some surgical repair, particularly if we think about it being from something related to maybe some type of an accident or traumatic accident. Sprains, we said with ligaments, we think about RICE, so rest, ice, compression, and elevation. If we do, again, have some tearing that needed to heal over a period of time, they could cast that area or even do surgery to repair those ligaments. So we think about ligaments, particularly in the knees and things like that, that not only have we strained those ligaments, but they can even tear that may need to be surgically improved. Okay. So fracture. So what is a fracture? What's a bone fracture? What do you think? Yeah, it could be a break in the bone. It could be a complete break. It could be a break in a partial break in the bone. And so when we think about fractures, there are a lot of different characteristics that describe not only what's happened to the bone, but also what's happening to the tissue that's surrounding the bone. And then why do we think fractures are painful? What do you think?
Nerves.
Yeah, so there are lots of things we said that not only innervate the bones, but surround the bones and the tissues, things like blood vessels and nerves, and it could damage one of the nerves or even put pressure or compression on those blood vessels and nerves that can affect blood flow and create edema and pressure, and that can create pain as well. So what can the patient do to help with bone healing? So some of the things that we think about can be things like decreased weight bearing, especially if we're thinking about things like our lower extremities. It could be immobility, it could be surgery, it could be healing of the tissues that are surrounding it. So many different things. So how are they classified? Okay. So we can classify by the extent of the break in the bone. A complete fracture is a break that goes across the entire width of the bone in a way that the bone is divided into two distinct sections, two or more distinct sections. And then an incomplete fracture is a fracture that doesn't divide the bone completely, but because it doesn't break all the way through. But again, we still are interested in doing things to help that bone heal and preventing irritation and damage to the things that are surrounding that. There are blood vessels that run through the bones. So again, just because we don't have a complete fracture doesn't mean that there isn't edema and pain and pressure, numbness and tingling, all those things that could go along with a fracture. Okay. So what does the tissue damage around it look like? We also can describe it by how is it affecting the tissues around it. An open or a fracture is where the bone actually disrupts the skin. So we can see part of the bone that's coming through the skin. Our biggest concern with that is infection, right? So if the bone has come through the skin, more than likely it's some kind of a traumatic accident or something like that, where it's probably not a very clean environment. And so things like debris and dirt can get into that wound. So very concerned about infection. And then a closed or simple fracture doesn't extend through the skin and it's not visible. So we can still have a complete fracture where the bone is broken that doesn't come through the skin on the outside, but then thinking about how has it affected that skin integrity. So then what causes the fracture? That's important as well. So knowing what causes it could help us to determine, again, how to prevent it from happening again. So different types of pathological fracture or spontaneous fracture, that's what I mentioned with the spine, and it occurs after minimal trauma. So not just the spine, but other bones too. So osteoporosis, excuse me, is a common reason that a pathologic fracture happens. Thinking about a fracture with something that has caused a fracture that if we have normal, healthy health, it wouldn't cause a fracture. So things like we said, if I trip and fell and caught myself on my wrist, or if I stepped off a curb, those kind of things from just the jarring of the bones together can cause a fracture. And it really, in a healthy bone, shouldn't do that. A stress fracture results from excessive strain or bone, thinking about things with athletes, excuse me, where you have a strain or sprain that has a ligament or muscle damage and it's extended to the bone as well. So that trauma has extended through and caused that fracture. And then a compression fracture is produced by a loading force. So think about this as something that could happen related to the pressure of our body pushing down on our spine. It can happen if we were in, let's say maybe an accident or a car accident where the force that's coming at the body has caused those vertebrae to press down on themselves at such a force that it's injured that spine. So one of the ways that we can help to either decrease muscle spasms after a fracture or to stabilize those bones is called traction. And we'll talk about kind of two classifications of traction that are used for very different reasons. Excuse me. So slowly and gently pulling on a fracture or a dislocated body part can help to decompress the muscle tissues that are surrounding that fracture, and then also to put those bones back into a better alignment so that it's no longer causing that pressure on the bones around it. When we have that increased pressure on muscle tissue, it can cause those muscle spasms to happen, further causing injury to the area around it. So why do we use traction? We said that it guides the body part back into place. There. Okay, we need a certain type of traction to do that. It stabilizes and realigns bone fractures. Okay, so it could be arms, legs, reduces the pain of a fracture before surgery. So again, we're thinking about reducing that pain, reducing muscle spasms, treats bone deformity. So we can think about things that, deformities that have happened, things like scoliosis. So we can use traction to slowly help to realign things like the spine. It could correct stiff and constricted muscles, joints, tendons, again, that are surrounding those bones. It can the neck and prevent painful muscle spasms. So some things can be done as part of kind of pre-surgery or part of an accident or injury, but then also thinking about something like a cervical traction, talking about the neck and prevent muscle spasms, is where they kind of have a kind of a Velcro attachment that goes on the head under the chin, and it slowly kind of pulls the neck outward and helps to stretch those muscles. And that can be done on an outpatient basis, and they kind of take it off, and it's done repetitively over weeks or months to help stretch those muscles. So it can be something that is, again, non-invasive, that attaches to the outside of the body, or if we're thinking about a fracture, could be something more invasive that truly goes into the bone and helps to stabilize it. So many different kinds of fractures, or types of traction, excuse me. So we're going to talk about two really distinct types. One of them is called skin traction. And it's called that simply because it attaches to the outside of the skin. So we think about, if I'm going to attach to the outside of the skin, and that's the only place that it attaches to, if we pulled really, really hard for a continuous period, we could damage the skin, we could damage the muscles and things like that. So skin traction truly is not used to put bones back to where they are. What it's used for is to help prevent those muscle spasms. One type I talked about was kind of where we said kind of stretching and pulling those muscles gradually to help them have less muscle spasms. We talked about the neck. But one other thing that we use is called skin traction. One type we'll talk about is called Buck's traction, and it's used for femur fractures, where we are simply decreasing pain until that person can have a surgical intervention done. We think about if someone broke their femur, that it's emergent, they go to surgery, but unfortunately that is not the case. If they come in the middle of the night or the weekend or something like that, we'll put them in something called a Buck's traction, where we actually kind of put the lower leg and it pulls on it very slowly to decrease muscle spasms until they go to surgery, which could be 24 or 48 hours. So strictly to reduce muscle spasms that accompany that fracture, we use it many times, like we said, with femur fractures, hip fractures, and it's short term. Something pulling on this, don't want that to be long term. And the purpose of it truly isn't to realign the bone or fix the bone. If we pulled that hard on it and tried to do that, we just damage the tissues. Yes.
So why do muscle spasms occur when you have like a fracture?
So the bones that are inside, if any break in those, it is interfering with the tissues that are around it, so the blood vessels and the nerves. And then what happens is when there's damage to those areas, edema happens, more fluid comes to the area, and there's pressure on those muscles, so they start kind of having spasms in that area. So with this, if we can kind of pull on the leg, using that, it decreases pressure on those muscles. And it can keep people, not only keep them comfortable, but it can decrease injury to those muscles and things. So it requires pressure on the skin to maintain that pulling force. We use a maximum of 5 kilograms of weight. So a small amount to, again, help to kind of pull that leg and hold that leg, but it's not enough weight or pressure to really put those bones back together. That needs something more invasive. This is a temporary thing. Okay. More than 5 pounds of weight will result in skin damage. So blisters, excoriated skin, and we don't want to put it over skin. So if there are, abrasions or injury to the skin or those kind of things, then we wouldn't do that. What it is it's kind of like a Velcro boot, and it has this loop on the bottom of it. So we have the patient lie on their back, and they have to stay in that position. And we make sure that the leg is straight in that alignment. We put this boot on there, and then there is a rope with a weight that hangs down from it. So the rope attaches to the end of the bed frame, and it hangs freely. We don't want it to sit on the ground. It wouldn't be creating any kind of pulling. And it hangs freely from that, and in that, it kind of pull that leg just a little bit to help it decrease those muscle spasms. Wrapping the straps too tightly can cause damage. Okay, so it can prevent it can cause something called compartment syndrome. And compartment syndrome is truly where the inside of the tissues has so much fluid and edema and pressure that it causes damage to those blood vessels and nerves in that area and can actually cause tissue death. So we don't want to do that. So if we were to add so much weight to it, we could damage those tissues. So we don't want to do that. It's truly a little bit of pulling on that area to prevent those muscle spasms. So we don't apply traction to skin that has abrasions or lacerations or surgical wounds or anything like that. We truly use these for patients that are awaiting surgery. We don't want to use it on someone who has vascular disease. They already have damage to those blood vessels down there.
Okay. So
Yes.
after surgery, will this not be done anymore?
Yes, they won't do that anymore. So the second type is called skeletal traction. And so we think of the bones, the skeleton, and this type of traction actually goes through the skin into the bones and helps them to be aligned and to stay where they're supposed to be. They can do this before surgery. So if someone's had an accident and they have lots of broken bones, we want to prevent damage to those muscles and blood vessels and things. And they also may let some of maybe that patient to be safe for surgery, right? So if I've been in a traumatic accident, I've lost a lot of blood, they may do this to put them back where they are to make sure that patient's stable enough for surgery and the next day to have surgery. They also can do this during surgery and leave it in there for a period of time to let the bones heal where they're supposed to be, particularly with multiple fractures. So it includes a pin or a wire and a screw, and they go through the fractured bone to help hold it in place. So after one of the devices has been inserted, again, weights are attached to that so that the bone can kind of be pulled and stay in that position. So even if we were to put this pin, again, it's not like a pin that they go inside and they put it in the bone to hold it permanently. This is a pin that kind of goes sideways through the extremity, and it's truly to hold it in place where it should be. And with that pin being in there, again, there's traction or weight that's pulling on it to hold it in alignment to let it heal after surgery, or it can be used before surgery if the patient can't go to surgery immediately. So maybe in the next 24 hours, someone is lost, they're not stable enough for surgery, all those kind of things. Because if we don't do this and hold the bones where they need to be, they can start to heal in the wrong place, or those tissues around it can become very damaged and even can start to become necrotic. So we want to put it in best alignment as we can. So skeletal traction puts the bones back into alignment. More invasive. So we can use a weight of 9 to 14 kilograms, okay? So thinking about, we're pulling actually on the bone, we can put more weight on that than we could the skin traction, okay? If we put more weight on the skin traction, it's just going to damage the skin. It's not going to go in there and actually pull the bone. It's going to pull the tissue around it. So it's most commonly used for fractures of the femur, the thigh bone, but I've also seen it used if they're doing surgery on the arm or something like that. But we tend to think about the long bones, particularly because there's so much room for those fractures in those areas. It's the preferred method when greater force is needed, and when the purpose of it truly is to put the bones back where they belong. Force is directly applied to the bone, not the tissue around it. It means more weight can be added to it, okay, used to reduce fractures, put the bones back where they belong. Okay, so it looks similar, but again, we're going to see the pins that are going through the extremities. Okay, so in addition to assessing the skin like we would with skin traction and assessing blood flow to the extremity, we're also going to be looking at where those pins go in. Okay, we're going to be looking for signs of infection. Many years ago, we used to do something called pin, and it's where we had something like some peroxide, and they would want us to kind of go around those pin sites and scrub off all the kind of scabs and things. But then we thought, that didn't make a whole lot of sense, because that is keeping that area free from bacteria and things. We were just kind of taking away that tissue that was trying to the skin. So now they don't really want, the physicians don't order us to kind of really scrub those areas. They might order us to clean that area, but we are kind of preserving what the body's naturally doing to kind of prevent it from getting infected. So what the physician order would be, if we were doing skin traction, then the nurse could put that on. So again, it's a boot that goes on the outside of the leg. We would attach the rope and the pulleys and have that patient to lie on their back. And believe it or not, the thought of actually kind of pulling on someone's leg to put that on there is really awful, but I always promise people you will feel so much better once we do this. And so having them lie on their back and putting that boot on there, putting the weight and then letting it hang freely, that small amount of weight actually kind of pulls that leg just a little bit, and it releases the pressure and muscle spasms on them. Usually skin traction is used 24 to 48 hours, and then at that time they're taken to surgery. So the physician will, if it's the skin traction, they'll order like Bucks traction or skin traction, it will put that on, and then they'll order the amount of weight. So 5 kilograms for skin traction, and then more weight for skeletal traction, 14. But they'll tell us exactly how much weight, and they're actually little round weights that you attach to the end of, kind of like a little metal hook, you put the weights on there. We don't ever take the weights off, okay? So the patient doesn't get up to go to the bathroom, or we don't take the weights off and turn them in bed, or anything like that. They have to stay in that alignment with the weight, okay? We can tilt their bottom a little bit and put a pillow under there, we can put a bedpan under there, but they have to have that constant maintaining of that weight on there, or else if we take that weight off and things like that, then they will have, again, those increasing problems with pressure.
How long is skeletal?
Skeletal traction can be used either temporarily, so maybe before surgery, but it can also be put in during surgery, and it can stay in there for weeks.
Okay.
But it does eventually come out.
Yes, yes, it does eventually come out. So I've taken care of patients who maybe have come in for trauma in the ER, and they put these skeletal pins in there to hold the bone, because the patient really wasn't stable enough to go to surgery for a big surgery like that. And then the next 24 hours, 48 hours, they've taken them to surgery. But then they also can put it in during surgery if that's part of the repair process of putting the back in and letting it try to heal naturally. They may, let's say they had multiple fractures in the lower extremity in surgery, they may put in some pins and things like that on the inside, but they may also put these on the outside and have them hooked up to some type of traction for a few days to weeks to allow those bones to try to heal. Another skeletal traction is called an Alizaroff, and we use it with kids, and it is where the bones don't grow enough, so maybe one limb is shorter than another limb. They can put this, the pins on, and then it has kind of this skeletal traction on the outside that has rings that go around it, and these rings hold the pins, and then every day we turn the pins to pull the bones a little bit more, and they can do that up to like 6 weeks to try to pull the bones a little bit more and increase growth of the bone.
So, if they have a skeletal traction in their knee, or like below the knee, I guess, how long can they walk with that in there?
No.
So if they have it for weeks and they're not doing do they constantly be doing the weight?
It depends on what kind of traction it is. It depends on what kind of traction. So kind of what we're talking about here is the patients that are in the bed and they're just hooked to the weights that cause the pulling.
Until it's done.
Right, right. The patients that are more longer term, so I would say like more than a week, things like the bone growing and that kind of thing, their weight truly is the
Just
turning
the
of those things.
Okay. So
Yes.
then in the bed, they could be there for 2 weeks just in the same
Yes.
position,
Yes.
and the weight is there the entire time
Yes.
until the doctor says it's done.
Yes.
Oh my gosh.
Yes.
That'd be horrible.
Yes. And so we can have lots of, weights and pulleys and all those kind of things. It may be have gone and done some kind of repair, and then they want to let it try to heal on its own some, and then they take them back. So it's really part of the healing process. So we have to make sure they're in proper alignment, that they're lying kind of straight, so that that pulling isn't pulling the bone in the wrong direction. If it's necessary for the patient, we've got to take the whole bed and the weights and everything with them. So we could take them for an x-ray or take them if they need to go to surgery or something like that, but we don't take the weights off to take them. In most cases, the traction will be applied for a number of weeks to months, but it could also be, like we said, before surgery. So we need to make sure we're doing neurovascular checks, that we're doing any type of, the patient's had any injury or had any type of surgery or anything like that. We want to make sure we're checking for nerve innervation, so numbness, tingling, sensation, and blood flow distal to that injury. So that means that if I had surgery on my hip, we're going to be checking blood flow to my foot, right? The part that's distal to that. If I had shoulder injury or surgery, we would be checking the fingers. And so as part of that, we're going to be looking at sensation. So can you feel me touching you? Any numbness or tingling to the area. We're looking at edema, we're looking at skin color, we're looking at skin temperature. So all of those types of things we're continually assessing, usually every hour for those patients, because if they were to have decreasing blood flow or the nerves were to be pressed upon, then they could have permanent damage to that area, and we don't have blood flow, then we have tissue death, right? So make sure that we're again assessing pulses in that area, any numbness or tingling. Can you feel me touching? You know, kind of which toe or finger am I pinching? Can you move them? And again, it may be a little impaired or slightly impaired if we have edema, definitely. It may be difficult to move, but can they move it in some way? Also thinking about they came from surgery, maybe they had put a medication in there to numb the area. So do we know that? Maybe they can't feel me touching it or wiggle it, but is it warm? Do they have good pulses? Do they have good cap refill? Is the skin warm? All those kind of things could indicate that as well. So some medications could interfere, again, with the sensation to that area. So what's our responsibility if someone's in traction? We have to know that the apparatus, the traction, has to be maintained at all times and good alignment, okay? So we don't want them on their side or getting up or things like that where the bone or the skin that were muscles could be interfered. If traction is not in alignment or there appears to be some kind of discrepancy, then we need to notify the physician. So if we're coming in getting report, we want to make sure that we look at the area, the site. So look at the boot, if it is a skin traction, look at the pins, and look at the amount of weight there. Is the weight hanging freely? It's not sitting on the floor, it's not sitting in the bed, there's not a bunch of blankets on top of it pushing down so that the weight is not hanging freely. We want to document the amount of pounds or the number of pounds or kilograms that is on the traction. Okay? We want to assess neurovascular status. We want to verify that it's unobstructed, again, that it's not kind of sitting on the floor, or it's not leaning against the bed, or there's not a bunch of blankets kind of pushing down on it so that that weight's not hanging freely. Performing our neurovascular status, sensory, motor assessments, again, all those things we talked about distal to that extremity, skin integrity, and notify the physician immediately if there's any acute changes in neurovascular status, okay? So I was hitting earlier, they could wiggle their fingers, they could feel me touching them, and now it's severely edematous. They can't move them, they can't feel me touching them. There's something wrong. So this kind of talks again, some of those things are responsibilities. Monitoring skin temperature, okay? Are the ropes hanging freely? Is the extremity in alignment? Checking circulation, the 5 Ps, and we'll talk about that in a minute. The type and the location of the fracture. So why are we doing it? Do we know why that type of traction is used? We want to make sure that patients are getting enough fluid intake. They can't get up and get it themselves, or are they staying hydrated? Are we assessing if they need to use the bathroom, right? There may be an overhead bar. One of the things that we want to do is to be able to use the muscles that they can still use. So if patients are in traction, they usually have a bed that has an overhead bar on it, and the trapeze that's hanging from it is kind of like a little triangle area that they can use to kind of pull up and move their butt, and also to help to, it's so they don't scoot down in the bed, those kind of things. And then make sure that those weights aren't up on the bed or sitting on the floor. They are hanging freely to do what they're supposed to do. Okay, so how do we assess neurovascular status? We're looking for pain. Has their pain increased? Okay. What are pulses like on that extremity? What's the skin color look like? Is it pale? Has it changed? Is there any paresthesia, which is numbness and tingling? Okay. Can they feel me touching them? Can they wiggle their toes? And we said immediately after surgery or something like that, they may have kind of given them medication or put a nerve block in or something like that. So is there a reason that would explain the fact that they can't feel me touching them, or they have trouble wiggling their toes? And then paralysis of them at all. So assessing immediately, after they've had a procedure, or assessing at the beginning of our shift, a baseline compared to an hour from then and an hour from then. Has any of those things changed? So let's talk about surgical options. We talked about traction as being external. Those pins go into the bone and come to the outside of the body. But if they go to surgery, they can also use pins and screws and plates to go inside and to help secure those bones in place, and those will stay permanently. So that's called internal fixation. So one of the options that they can do is called an open reduction. Open means that they go inside the skin. A closed reduction may be, let's say that your shoulder comes out of place. You go to the ER and the doctor pulls on it and puts it back. That's a closed reduction. Okay, they're not going inside your skin. But an open reduction is where they go into surgery, they open the skin up, and they're putting pins or screws or plates attached to that bone, and they're going to close that up and they stay in there permanently. Okay. So it involves stabilizing the broken bones. It's usually for people who have fractures in which bones can properly align. So if someone had a fracture that may be just a small kind of a chip on a bone or something like that, and they couldn't go back in, kind of repair and replace and put that in there, they may not do that. Okay? They may do other things to help rest the bone and let it recover on its own. But these are for bones that truly can be supported and put back together. We tend to think of these in the extremities again, our arms and legs, hips, shoulders. Reduction is getting the bone lined up together. Okay? Internal fixation, we said, is stabilizing the broken bone on the inside, and those pins and plate screws, they stay there permanently. And the repair is due to an injury to a bone, a fracture to a bone, or many fractures. So let's look at a femur fracture. The type and the location of the repair would depend on what's the extent of the injury. We'll kind of look at some examples here. Excuse me. This extracapsular fracture. So it's in the movement of the joint. They may put pins in here, but we can see if the fracture is down lower, they may need supporting here. Or if it is lower, then they may need something other and supportive. So again, the kind of hardware that they use really depends on how much weight bearing there is. Is it at a point where the bone is affected at a joint where there's a lot of movement? So there can be different types of hardware that are in there. So let's look at maybe some of the causes. So we think about broken bones, we think about surgery for bones as something that happens in like a traumatic accident. But there's also surgery for bones that can happen from wear over time, so chronic use. And one of those reasons is called osteoarthritis. Okay? Osteoarthritis is chronic and progressive. So it can happen as we age. It can happen in younger people, maybe who have been especially people who maybe are professional athletes and they're involved in a lot of trauma to the bones or repetitive movements that happen. It could be someone that works in like on a factory, on a line that does repetitive movements and motions. And so those bones have been, had a lot of edema and the fluid that surrounded them and caused them to gradually break over time. So what is the difference between osteoarthritis, chronic and progressive wear and tear, versus rheumatoid arthritis? Okay, arthritis simply means inflammation of the joint. So inflammation of the bone at the joint, but it's caused by different reasons. Arthritis is, again, wear and tear on bones. Could be from repetitive motion. It could be from someone being overweight and putting weight and pressure on their knees and hips and ankles. Okay? It could be from someone who has repetitive motion, like at work or sports or things like that can cause breaking down of those bones in the joint. Rheumatoid arthritis is an autoimmune process. So an autoimmune process is where our body makes antibodies that kind of attack our body. in particular with rheumatoid arthritis, those antibodies our body makes attacks the joints. So they attack the cushioning in the joints, they attack the bone, and they cause inflammation in the area. And that inflammation can damage those bones in the area. So the causes are different. Rheumatoid arthritis happens at a younger age. Autoimmune disorders usually start to appear at about the 20s and 30s. Okay? That inflammation in the area and antibodies can destroy parts of the bone. So what we would do with rheumatoid arthritis would be to give patients medications many times that decrease that inflammatory process, autoimmune medications, and also doing things to decrease inflammation. Osteoarthritis, many times people will treat with NSAIDs or things like that. We have to be careful with patients that are taking NSAIDs like ibuprofen or Motrin or even prescription strength because they cause GI bleeding, right? So patients who are taking medications for arthritis pain to decrease inflammation chronically, they don't take it longer than necessary, they don't take more than necessary because it can damage the lining of the stomach and cause GI bleeding. Osteoarthritis usually happens progressively as we get older. Okay. So again, some of the differences. Osteoarthritis is degenerative. It happens over time, wear and tear. Rheumatoid arthritis is an autoimmune process. The cause of rheumatoid arthritis is inflammation in that joint capsule that damages the bones. And osteoarthritis is that cartilage from wear and tear of use over and over. Rheumatoid arthritis, we said, happens in a younger population. It starts to happen at that age. Osteoarthritis happens progressively as we get older. And commonly affected areas with rheumatoid arthritis are small bones and joints, particularly hands and ankles, things like that, that the inflammation can be so detrimental it causes deformities. Osteoarthritis is more weight-bearing. We think hips and knees and ankles. Okay, so we think about arthritis. Some of the effects of it can be that it damages the joints, but for different reasons and in different populations. Okay. So what if there is damage to the joints and we need to do surgical repair and repair some of those things in the joints? What happens? So there can be a couple of different things that happens. A couple of procedures. An arthroplasty is repair or replacement of that diseased joint. So in the joint, we think about there are two bones that come together along with that synovial fluid and the cushioning of tissue. So are we repairing all of that or some of that? And so this is where some of those terms come in of how invasive that surgery is. A hemiarthroplasty, hemi means a hemisphere or a portion. So that's a partial arthroplasty. So maybe we have two parts that come together and maybe one bone is still in good shape. So we're repairing part of the other side. So is it both sides? Is it one side? Okay. A total arthroplasty, we're replacing the whole joint. So it's both sides that come together. Okay. So if we're thinking about the hip, we're thinking about the femur, the head of the femur. And if it is a total, we're also thinking about, is it that joint capsule? So this one, it just has the head of the femur, the joint capsule there, that bone in the pelvis is okay. But in this one, they're both kind of from rubbing together for so long, they're both damaged. So they're going to replace the inside of that pelvis and they're going to replace the head of the femur. Difference between kind of how extensive that surgery is. These are scheduled surgeries. So if someone came in and had an accident, this wouldn't be the kind of surgery they would do. More than likely, it would be a femur fracture we talked about previously, where this bone was broken at some point. Okay? This is from wear and tear from arthritis in the joint. Okay. So it's a scheduled procedure due to those degenerative changes that happen, the wear and tear of bones. And remember, surrounding those areas are ligaments and tendons and cartilage, all different things that after surgery, we're going to be checking for problems with their neurovascular status. So assessing skin temperature and movement, sensation, cap refill, all of those things we talked about. The reasons for it are to reduce pain. If we don't have that synovial fluid in the cushioning between those bones, it can be very painful. They can have parts of the bone that break off in there. Okay? It can reduce inflammation in the area from those damaging tissues. It can correct that joint deformity. So if there's so much damage, this joint, this femur part can actually slip out of place. They may have a limp, so they're putting pressure on the other side. And so we want to make sure that they're safe, they're not going to have falls, and it can increase their mobility. They're able to move around and ambulate and do things without pain. Yes?
Are they able to do it with little ones, like the fingers? Like, to fix, like, help RA?
Usually not with RA, usually not.
Just with osteo?
Mm-hmm. Mm-hmm. So what happens with total hip replacement? Our patients go in. I'm gonna give you the deep and gory details. So this is a very invasive surgery. It lasts hours, and it's if you get the chance to go to surgery and see this, it's a very bloody surgery. There are hammers and saws and all kinds of things. So what happens? Diseased head of the femur. They kind of cut that off. They're going to drill down into the femur to be able to put the femur, the head of the acetabulum and the neck of the femur down in here, so it's stable. And then they're going to hollow out this part of the pelvis if it's a total, and to kind of hammer in this this capsule in there that the head of the femur will fit into. So patients have edema, they have pain, they have bruising, and those things are normal after surgery. So we'll talk about what the skin looks like too, but there's a lot of pulling like that, and there can be a lot of blood loss. So our patients, particularly that are older, that are more frail, they may need blood transfusions afterwards, or at the minimum, we'll be watching their CBC, giving them fluids, maybe even giving them iron, those kind of things to make sure we're replacing blood. This is kind of what femur in the head of the acetabulum can look like with those degenerative changes. And the more they rub together, the more the chipping of the bones happen. It happens and gives them pain and inflammation. They can't put weight on it, all those things. Okay. So after a hip arthroplasty, either a total hip arthroplasty, sometimes it's called a replacement. So those kind of names go synonymously. Some of the things that we're looking at, we're going to look at the incision, right? So we're going to look at the incision. When they first come back from surgery, they're going to have these steri strips on there, but they're also going to have a big, long dressing. And one of the things after surgery is we're monitoring, of course, we're monitoring respiratory status, we're monitoring cardiac status, we're monitoring neurovascular status, we're monitoring for drainage. So we can imagine we've gone into this joint, which is kind of an open capsule, and there's going to be blood and fluid in there that have accumulated. So most of our patients that have either a hip surgery or a knee surgery or some kind of a joint surgery are going to have a drain. Most of the time it's a JP drain or a Jackson Pratt drain. And so they'll have a little hole where that drain will go in, and it will be pulling serosanguinous fluid. So it'll look really bloody. And there may be quite a bit of blood, but then it should slow down the second day. And usually by the second or third day, the physician will either pull that or they'll tell us to pull it. If they have a drain, and we've been told it's okay to take that out, most drains are not sutured in. Okay? We want to look at the outside to see if there's any little suturing that in. If there are, then we could clip that with scissors, take that suture out, and then we simply just pull this right out. Okay? It's in there about that far. We'll pull it right out. If you are doing that and you meet pressure, don't pull it hard because it could break. You should, I've never had any pressure, so you shouldn't. It should just come right out. But if you do, if it's hard to pull out, then stop and call the physician. Okay? And then there still may be a little bit of drainage out of here, but they're not going to have us pull that out until the drainage in that drain has slowed down a lot. Usually, like we said, 2 to 3 days after surgery. Have you guys like empty drains and things like that? So with those JP drains in particular, they're kind of like a round bulb, and the suction in that is kind of what pulls that fluid. So after we empty that, we want to empty it and measure the exact amount and write that on our output. But then we also want to squeeze it together before we close it, and that's that low pressure and kind of a suction that's pulling on that. Okay. So the first dressing change the physician will always do. The surgeon wants to change the first dressing. So if they come back from surgery and that dressing has lots of blood on it, we don't want to take that dressing off. What we would do is call, many times they'll tell us to reinforce it, to put more dressings on top of it. And that's simply because some of the dressings that they put on there in surgery actually cause a little bit of pressure that holds against that incision. So they don't want us to mess with that. But they will write for us to change the dressing. So we need an order to change a dressing. Okay. So usually after they change that first dressing, they'll want us to change the next dressing. We'll have a physician's order for that. And they have these series strips on here. We don't ever want to take those off. Okay. Those are, again, to help. There's usually staples in here, and these are, especially, with a joint, there's movement. So we don't want that incision to open. So we want to leave those steri strips. We want to document what the wound looks like. Okay. So we are looking for the incision to be well approximated. What that means is that the incision is close together, it's not opening up. We want to document if the staples are intact. Okay? So even with edema in the area, that should not be opened up. Those staples should not be coming out. And again, those steri strips intact there as well. This one's kind of orangey. It looks like they put betadine all over it or something. But these will come off after they go home in the shower, and they will just start to come off. So they're there to hold that in that area of movement. Okay. There's probably going to be a little bit of edema. Okay. Not enough edema for that to open up. There may be bruising. Usually there is bruising. Okay. And there may be a small amount of drainage, that's serosanguinous drainage. Of course, we don't want yellow drainage or foul-smelling drainage. And we also want to document the color of the skin. It should be warm and pink, right? So anytime that we're asked a question about assessing, many times if we see warm, we think, well, that means infection, but it should be warm, right? So we think warm, cold, we want it to be warm. Okay? And we want it to not be pale. Okay? Yes?
How soon can the patient ambulate after this?
We usually ambulate patients a couple of hours after surgery.
Okay.
So help them to sit on the side of the bed. Physical therapy usually is the first people to come help the patient, but if it's a weekend or something like that, maybe. But again, we need a physician's order to tell us what kind of activity that patient would have. So coming from surgery, if they don't have an activity order, we want to ask them, is it bed rest? Is it up with assistance? That kind of thing. One of the things we don't want to do is to put that joint out of alignment. And so with a hip repair, what we do is we have kind of these pillows that are called abduction pillows. Some of the things that can cause this hip that we put in here to come out is if we abduct too far or adduct too far. So we don't want them to cross their legs, and this prevents them from crossing their legs. And we put if they cross their legs, this hip that's just brand new and is trying to build connective tissue could pop out. So having this abduction pillow is extremely important, and I've gotten yelled at before. So keep this on. And again, if we are helping them to get up and to sit on the side of the bed, take this pillow off, help them get on the side of the bed, but also teaching them not to cross the legs, things like that. Other types of precautions would be that when they are sitting down, we don't want them to sit in a chair that's really low. Again, that could cause those hip joints to pop out. Okay? So we want them to sit in a chair that is a hardback chair, solid bottom, not sitting down in a car that has a really low seat, those kind of things. And some of these precautions they're going to want them to do for even up to 6 months while those ligaments are healing. So we're going to teach them these things. And again, these are scheduled surgeries. They should be learning these things before they come as well. Yes.
They wouldn't do both hips at the same time, right?
Rarely, I've seen it, but rarely. Now they'll do two knees at a time. They can. I think I've maybe seen 2 hips once.
Okay.
But it's a much more invasive surgery than the knees. Yeah. Again, some of those precautions. In sitting, don't bend the hip above 90 degrees. Okay. So again, we don't want to sit in something way down that's going to cause the hips to have more pressure to come out. Don't bend over to things on the ground. Again, we're doing the same thing with causing that more of a 90-degree bend in our body. So have somebody else pick it up. They also give them these long metal grabbers to pick things up. Don't the leg, no twisting, no rotating, and don't cross the legs when sitting. Again, is causing the same thing to happen. Let's talk about some knees. So we can do total replacement of the knees. Again, we have 2 bones that are coming together that should have the cushioning that prevents them from rubbing together and also helps to have good movement. With wear and tear, those things, those bones, that cushioning of the bones can become damaged and wear out, and we can damage both sides of those bones. So total knee replacement provides significant relief of pain that causes that arthritis, and with surgery they can have mobility with decreasing pain. So again, what are we expecting after surgery? We're probably going to have a drain. It's a joint, it's an open capsule, kind of a space in there where fluid can accumulate. We're going to have an incision. We're going to look at it and see, is it clean and dry? Is it pink? Is the incision well approximated? Are the staples intact? Okay. Maybe some bruising, that's normal. Okay. It may have a little bit of edema, that's normal. Okay. So what's our baseline when they come? What's our baseline when we get report compared to what happens during our shift? And then they also may have these series, or sometimes what will happen is they may put on steri strips if there's increasing edema and things like that. So what would happen if we were to look at the incision and there was edema and it looked like it was pulling out a little bit or staples were coming out, we'd notify the physician and they may come and they may assess something like infection, but they may also put these strips on there to help reinforce it. Now with the knee, our purpose of kind of helping them to rehabilitate is movement. We think about the hip and we think, well, we want them to get up, but most of the time, if they're in bed or sitting, that hip is pretty much staying in alignment. We're bending it and moving it. So as part of their recovery, we're going to help them to get up. They're both going to use a walker, again, depending on how much weight bearing. Immediately after surgery, they're not going to be able to put their full weight on it and just walk with no problem. It's got to heal. So they're going to be using a walker. And we want them to bend the knee and have increasing movement and mobility. So physical therapy may work with them to do exercises, and they also may use something called a continuous passive motion machine, or a CPM machine. And I've been using these for 25 years, and you'd think they would look fancier and be more advanced, but they're the exact same kind of looking machines that they put in the bed, and they kind of attach the leg to it with Velcro, and it helps the leg to bend and straighten. And it's passive because the machine is doing the work. So physical therapy will set the degrees at which the knee will bend. In the beginning, it'll probably start at about 10 degrees, bending a little bit, but then it'll advance. Even when we're to rehab after they leave us, they'll continue to increase that bending until they can bend to about 90 degrees. So we don't want that knee to become stiff and not bend. We also don't want them to lay in the bed and not have movement. We know that patients that don't get up and get out of bed can have pneumonia, they can get blood clot, they can get stiffening, and fluid can accumulate in there and cause more pain and problems. So getting up and moving is important, and part of this movement is that passive movement in addition to their active movement, with using those machines or physical therapy, helping them to kind of bend those extremities. So what to avoid with knee surgeries to prevent them from coming out of alignment or damaging those knees that have been repaired. We don't want them to twist or cross their legs again. We're putting too much pressure on the knee. Don't sit in chairs, again, that in which the seats are too high, where the legs are going to be dangling, or sitting where they're bending the knees. So kind of what we think about is kind of a kitchen chair, hardback kind of chair, in which they can sit where they have their knees supported and not kind of hanging and dangling. Don't keep standing for extended periods of time. So we don't want them to sit too long. We don't want them to stand for too long. Don't sleep on that side of the body that's had surgery. We tend to put the weight of the on that side, and we don't want to do that. Do climb one stair at a time. Again, in doing that, going with the good leg and then following with the surgical leg, we're not putting a lot of pressure on that leg. Right? Do avoid excessive kneeling. So kneeling, again, putting all the weight of the body on the knees can be damaging. And then lie with the legs straight as much as possible. We don't want to put a pillow under their knee. Again, that can cause contractures in the joints. So if there is edema, what we can do is put pillows under the ankle area and to help elevate it, but we don't want to put them under the knee where the knee is kind of bent over it. Again, kind of dangling there and can cause fluid buildup in that area. All right. So arthroplasty is repair of the joint. Okay, so what kind of things are we monitoring? We want to make sure if they have a drain, okay, hemovac drain, a JP drain, that we're emptying the drain. We're recording fluid or recording what it looks like. Is it serosanguinous fluid? Okay, it should be kind of a bloody fluid. If we are recording the amount of fluid and it starts increasing in amounts, that could be concerning. They could have bleeding inside. We may need to give them oxygen. Did they come to surgery with oxygen? We're managing respiratory status. In that, we would want to elevate the head of the bed at least 30 degrees after someone has surgery, unless it's contraindicated, they had some kind of a spinal something. So elevate the head of the bed, monitor O2 stats, okay? Use incentive spirometer every 2 hours. Again, any post-surgery, we want to prevent pneumonia. And deep breathe, okay, that's part of the incentive spirometry, but we want them to also to take a big deep breath and cough. Okay. Recording intake and output. Are they on bed rest? Usually after joint surgery, they're not on bed rest. Is there some reason they might be? So knowing their activity orders. Okay. Dressing change does that. Do I have an order to do that? Is the physician going to do that? Is it the dressing soiled or something like that? I need to call the doctor. What's their diet? Okay. Again, after surgery, it could be clear liquid. They could advance. One of the common things I see is maybe after surgery is clear liquid and then the doctor doesn't write to a diet. So if it is the next day and there's no reason that they should be able to eat, we need to make sure that we follow up on is their diet advancing like it should. Checking neurovascular status every hour, usually for the first day. Then it could be every 2 hours, and then go to every 4 hours. So it's important that we check the neurovascular status of the leg that's had surgery, distal to the surgery or the injury, but we also check it compared to the other leg, right? Vital signs, maintaining the position of the operative area, knowing what precautions that they have. Physical therapy usually will initiate ambulation, things like that. So do we need to contact physical therapy? I always think it's a great idea to go in and see what physical therapy is teaching them and doing. We can also look at the notes from physical therapy and see what their kind of assessment is of that patient. Okay. Many times physical therapy will assess that patient, do some ambulation or things, and then they will make the recommendations to the physician about what their activity should be. And that kind of determines what the physician will write. Encouraging fluid intake, again, keeping our patients hydrated, making sure that they're eating. Are they nauseated? Are they in a lot of pain? And treating and assessing that. They may have anti-embolism stockings or hose or scuds. So what are we doing to prevent blood clots? patients that have joint surgeries are at an increased risk of having blood clots. They have a lot of drainage of blood inside there, and also they're less mobile than they were before. So we may be using compression hose or scud. They may be getting some type of a blood thinner like Lovenox in their belly until they go home, and avoiding any adduction. So not crossing the legs, not hyperextending them by squatting or bending over, those kind of things. All right. Well, let's go ahead and take our break.
I don't know, it's not one. I just moved houses and I found it and so it's somebody's to live with. I think it's pretty so like love.
Oh.
And there's a little horseshoe because Kentucky has horses. It's not rocket science. I know, I'm already done. I'm already done with it. But it's ridiculous, like why is
I know, I was looking at your notes, I was like, I bet it took like 3.5 pages of notes.
Yeah.
How many notes did y'all take?
I'm working on the 10th page.
Are those my notes part? How many pages did you take for notes? I know it has to be a lot.
stopped. Well, I stopped like kind of like,
She
I
said
stopped
I
like 20
stopped.
minutes ago. No, actually, before like 10 minutes ago, because
Yeah.
I'll probably spend the rest of the day on myself because I can't keep up. So,
I'm gonna finish it.
but mine is.
I'm gonna put the rest of my pictures in.
I stopped at the hip, like after the arthroplasty, that's where I stopped.
I started copying your pages
One,
and I write them down.
2, 3. Okay. 4.
But my computer's about to die,
Five.
so.
And this is 6. But also, I'm like, I stopped at arthritis versus rheumatoid arthritis, so that's. If I was caught up, I could definitely see myself being at like 10.
Yeah.
Yeah,
I'm just gonna finish it by myself today because like I can't like try to write that down and then try to listen to her because I'm not gonna like be able to put 2 and 2 together.
I quit writing it and I started copying and pasting it. Brains. Stress. Yeah, because she goes so fast.
Well, I only write it down just because I feel like I've been learning better by doing that, like knowing like that I see what I'm writing down, you know.
What I do is usually I copy, not word for word, usually, but put it in like sense.
And I try to highlight like important things, but
And then like when I go back in the textbook and look, I write notes out next to it, but.
also the test was supposed to be in 5 years.
I know, well, I really tried to say that out loud.
Well, someone did, but about.
That's responses to me, whatever.
But she said, I think she said like you should be ready for anything, and then she said I'll check on it.
For anything.
Well, it says in Canvas, it's over week 10, and week 10 is on Canvas.
I didn't even look at it, I was just like.
Which, I mean, like, it's hard just to go over it and go to class, but like, I.
You're good.
You're like not even in the way. You got stupid.
Okay, about how I'm looking
You are so.
I'm very excited, but I'm also very worried because I don't want to make it gross.
I don't think you can.
What are you talking about?
Chai tea. So how much should I put her in?
So what I do, if I'm
Yeah,
drinking
I
a hot chai tea.
I know, I feel like they probably do have it.
I
we wear them enough though. Yeah.
About this much, I
It's
feel
just
like.
like, I don't really like
And then this much milk.
Yeah, and I got it from Walmart, so.
And I heat that up in the microwave.
Okay.
And then I have a little frother, so I froth it.
Like,
And pour
low-key,
it
like, giving a
in,
vibe
and then I
today,
make
like,
one stir.
you know, I went to Orlando, you went to
And I
Georgia,
turn it
like,
over.
you
Okay, so
had
basically,
vibes.
together. And then pour it into the tea after
I
it's
asked her, I said.
Okay, so
what
steep
was,
tea,
like,
then I gotta heat up my
what was
creamer,
doing
froth it.
You better
Like,
write
so
this
they
shit down.
literally said, like, it was.
And how much should I put? Like,
How much do you put of your creamer? Well, it depends how
And so
sweet
I'm
you
just
like
like,
it.
okay, so
yes,
just a
like,
mild.
I'll let you
Of
know.
your
Like,
personal
so
preference.
So I should froth it
over this,
before
but
I
it's
put
still
it
like,
in the tea.
it's. Like, it's in there, so of course, everybody was gonna be using it. And so then I went and looked at B12, and
Okay.
it says that it's 11 and 12
Of tea, but I take the tea bag
So
out.
she was like,
Right.
"Oh, I'm gonna have to go back
Yes.
and look
Okay,
at that." And I was like, yeah, you are.
I think I'm gonna
because,
do hot.
like, it just made no sense. So I was like, are you gonna go back and like change? Like, I said, it's week 12, quiz still going over. I'm just saying, you should have changed something, because like, Bryce is the, yeah, she like said something like literally like right after.
I was like, I thought I was just gonna read.
When I had a mono, this whole one I swelled up like a big.
Like, I was even gonna get great on this quiz. But every time she was concentrated in that grade, okay, so great. Because like, things going on there.
And then there's a hotel like on Holiday Inn, like right
I'll
across.
talk to you like that, okay?
Like my fear, I just like this now, nobody knows what it has to know the others, and so like as it's like. It's gonna take the rest of the time. Well, this is the only slide. This is the only one for 11. My ethics thing is just
It sucks.
So 2 weeks from today is ATI. Okay, so,
and our third test.
I'm sorry.
And our third test.
Yes. So you have your third test. We'll come back at 1, we'll take ATI, okay? ATI, again, we are taking it that day. It is something for you to really just kind of prepare for the final, okay? So it is covering things we've covered in class. It doesn't hurt your grade, anything like that, okay? But I think it's a good review of information. What else?
So we don't have to assume certain, like, the 2 or anything, or like a level 2 or anything on it, we just take it at our.
Basically just
Right.
Okay.
Right. It's a little bit different than the test you've taken before in that I kind of filtered questions, not the question by question, but topics we've covered in here, and pulled this together. So what it doesn't show is it doesn't show, you know, us kind of compared to other schools or compared to things like that, that some of the other statistics will give us. And it will still give you a percentage, kind of the questions that you got right, and it will give you the areas that you need to brush up on before the final exam. Okay. Next week, we're covering gastrointestinal. There's a whole lot of stuff with gastrointestinal. In that, truly, we're starting kind of at the top and moving all our way down through the intestinal system. So we'll talk about some disorders that happen along the way, and then some complications that result from that. Okay. And then that'll be for this exam coming up. So not to forget that we still have part of our neuro that we talked about. So things like seizures and stroke that are going to be on this exam as well. Okay, so not to forget that. Okay. So let's continue talking about post-op care. So post-operatively, we said our neurovascular status, and we're also assessing for things, of course, pain. We're assessing for nausea. We're assessing for respiratory problems, particularly in our patients who we said may be older patients, who may have lost some more blood than would in smaller surgeries. And so we may see some signs of anemia, things like looking at respiratory status, looking at our CBC, looking at skin color. Patients may be pale. In the CBC, their H&H may be low, things like that. Doesn't necessarily mean they'll transfuse blood. Usually we won't transfuse blood for a hemoglobin less than 8 in patients that are symptomatic. But what it does mean is our patients are going to have IV fluid. Many times they'll give them iron. They'll give them stool softeners to prevent constipation from the iron and decrease mobility, those kind of things after surgery as well. And so remembering if our patient is a little bit anemic, they're already weak from surgery, if we're trying to get them up, we don't want to get them up by ourselves. Okay, remember these people have just had surgery. They're not very steady on their feet. We do need to help them to use a walker correctly. So we need to know how to use a walker correctly. But we want to have one person on either side of them. We don't want them to fall or get injured, and we don't want to injure ourselves either. So let's talk about pain. So assessing pain at least every hour and as needed every time we come in and check on our patient. Are they having pain? Monitor for bleeding, right? We're going to be looking at the drain. We're going to be looking at the incision site. We're also going to be assessing signs of anemia. Do they have bleeding on the inside? So they may have anticoagulants, like we said, ordered up to 4 weeks post-operatively to prevent blood clots. Are we giving Levinox in the belly? Many times they will do that. They will go home sometimes with Levinox that they inject in the belly up to a couple of weeks after surgery. They're less mobile. They're increasing risk of blood clotting and things like that after joint surgery. Other ways to prevent BVTs, okay? Getting up and moving, encouraging patients when they're lying in the bed to point their toes to point it out and then point it back up. So doing heel flexes in the bed. To report to us if they're having any calf pain. We don't want to rub the calf. Again, if they were having a blood clot, then this could dislodge that blood clot and it could go to the lungs and cause a pulmonary embolism. We're looking for things like redness and edema in the calf, okay? That edema we're also going to see in the lower legs, affecting our neurovascular status in our feet. Elevating the pressure on the ankles. So again, we know that if our patients are less mobile, those little heels could get excoriated. Sometimes we put kind of Mepilex or something on the heels to prevent it from rubbing. But also we could also elevate the ankles with some pillows, encouraging our patients to move in bed and to help them to get up. Okay. They may also be on medication that has decreased pain they've given them in surgery and then post-operatively. So pain is going to be a huge thing that we're going to be assessing and treating after surgery. In surgery, they may have general anesthesia, so they're going to be asleep, they're going to be intubated. But during that time as well, also put something like a nerve block or what's called regional anesthesia, kind of like an injection of something into that joint to decrease the pain in that area It only lasts about 6 to 8 hours. So that pain is going to come back fast and furious. So we still want to assess for pain. So that's a reason why after surgery, they may not be having a lot of pain, but it will start to come. Some physicians will have an IV where they'll give them IV acetaminophen. And we can actually give this acetaminophen in an IV formula, and it decreases inflammation, it controls pain. So that may be something that's ordered. It's a continuous kind of IV. They may have a PCA pump. So with a PCA pump, our patient has to be alert and oriented enough to understand the purpose of that. Ladies, quiet please. So with the PCA pump, the patient is controlling their analgesia. They need to be able to understand to push the button. We need to be monitoring every hour with that PCA pump. How many times have they pushed it? How much medicine have they gotten? Is their pain relieved? What's their respiratory status, right? So the settings on a PCA pump are very specific. The physician will order how much medication is with each injection, what's the cutoff every hour, what's the total cutoff. So there's a lot of things we program into a PCA pump. There should be 2 nurses that monitor that information we put into a PCA pump. And so we're going to be monitoring that as well. We're also monitoring, does it help with pain? Okay. Could be a couple of reasons it's not. Does the patient not understand about pushing the button? Is it not helping with the pain? So sometimes it's just not enough to help with pain. Or if they don't understand or aren't able to understand about pushing the button or physically can't push it, then that's not the right kind of pain medicine for them. So we may need to contact the physician and they may change that, take that out, give them oral medicine, give them IV medicine, something like that. Even if they have something ordered, is it effective for that patient? We may be using ice. So many times with surgery, they will have using something like an ice pack or what's called a cryo pack. And it's like, it looks like a cooler, but it has a big tube coming from it. And we fill it full of ice and water. And it is fantastic. It is like, it looks like a big heating thing, and it wraps around the extremity, and that cold water circulates through there. One benefit of that is it keeps the dressing dry. It's not like putting a big wet ice pack on there, and it continuously circulates, so it's not like freezing cold ice that sits on there that can cause damage to the skin. So it's something like that ordered. Administer heat or cold to a patient, we need a physician's order. We cannot put an ice pack on a patient without a doctor's order. We can't put a heating pad on a patient without a doctor's order, simply because heat and cold can damage tissues, okay? So if we want to get a cold washcloth and put it on someone's forehead, that we can do that. But that involves ice or any kind of heat, okay? Medications, again, it may be that we're giving it in, maybe we're giving them oral medication like a Percocet, but between breakthrough of that, let's say maybe scheduled every 6 hours, they get oral medication, but maybe they also have RN medication for morphine for breakthrough pain. So we want to assess between the times we're giving pain medication, is it effective? We also want to make sure that we are pre-medicating patients before they do physical activity, before they work with PT. And that's any of our patients assessing pain. If we know that something painful is going to happen, we want to administer pain medication up to 30 minutes before that. So this is for any of our patients that are having dressing changes that could be painful, that are having procedures that are painful, that are getting up and working with physical therapy that can be painful, and particularly people joint surgery, we want to do that. Could also be medications other than just pain medicine, could be medications for muscle spasms, medications that maybe are numbing or things like that. So there could be other things other than just strictly pain medicine. We want to educate patients about those precautions to avoid kind of moving that joint out of place, but also educating them about pain medicine. Is it a scheduled medication? So will I bring it every time it's due? I also tell patients that doesn't mean I don't want you to tell me if you're hurting. I don't want you to sit and watch the clock and think I can't have pain medicine for an hour. That's not your job to watch the clock. That's my job. So if you're hurting, I want you to tell me. And we want to make make sure we're assessing. Is it problems with neurovascular status? Is there increased swelling or lack of blood flow or things like that causing pain? Or is it that they need additional pain medication? So we might have something additional we can give them, or we may need to call the doctor to see if there's something additional as well. Patients that take chronic pain medication may have a very high pain tolerance. Now, we don't want to give them so much pain medication we knock out the respiratory system, but they may add something like a muscle relaxant or something like that in addition that can help with pain. So what to expect after surgery, right? So we can expect that, and patients should expect a pain management plan. I like to go over with patients what their PRN medications are and if they have any pain medication scheduled. So these are some things that you may experience. I want you to let me know because they're subjective, right? Are they having pain? Are they nauseous? Are they itching, which could be a reaction to pain medication? Are they having trouble breathing, shortness of breath, anything like that? Within the first 24 hours, we're going to get them up. Physical therapy is going to get them up, and we're going to help them to sit on the side of the bed and to get up and walk. Okay, prevents pneumonia, prevents skin breakdown, prevents blood clots. Learning to use a walker or a cane. Patients that have hip and knee replacements are going to use a walker. As they progress with more mobility, after they go home to rehab, they may transfer to using a cane temporarily. They're going to be using range of motion, either passive range of motion where PT is helping them to move or using that CPM, or active range of motion, which is them getting up and walking with our help. Practicing active range of motion, so what kind of exercises should I be doing? And PT will be teaching them lots of exercises. Treating pain, assessing for edema, following precautions not to injure the new joint. We're going to be teaching them those things. And then several months of physical therapy, okay? So they're not going to leave us in 3 days, able to just walk out the door and nothing further. So again, all of this education should be reinforced after surgery, but they should be learning this before surgery as well, that they're either going to go home with physical therapy, home health, or they may go to a rehab facility and do more physical therapy. Of pain medication, not only to control discomfort, but also to increase mobility. It is important if we're asking them to do something like getting up and moving around, those kind of things. They're afraid of pain, so we assess pain and we pre-treat for pain as well. We want them to get up and move around. It's necessary. Also, what we teach them is if you start to have pain, stop, rest. Okay, don't over exercise, don't overdo something. Limit exposure to painkillers, opioids, those kind of things. When they go home, they're probably going to prescribe them things that are an alternative to narcotics. In the hospital, we may progress from IV pain medicine to PO pain medicine to Tylenol or Motrin. And they may include also in surgery, again, numbing that area. So immediately after surgery, they may not have a lot of pain, but they will. So we want to make sure we're adequately assessing and treating. What complications? What are we looking for that says that something is not right? It could be a wound infection. So again, looking at this wound down here, we have a lot of edema. We have the wound that's not well approximated. It's starting to pull apart, okay? We have, these are sutures, and sometimes it looks like they're pulling out. They shouldn't be doing. We see increased redness, we can see drainage, edema, all of those things. And this wound up here, it looks like it is healed, so maybe this is post-operatively, but they may have a joint infection, a wound infection inside the joint, increased swelling and pain and edema. And believe it or not, patients may, they get an infection in that joint, have to come back. They take all the hardware out. They will have to take antibiotics for 6 to 8 weeks, not put weight on it because there's no hardware in there. And then after it's healed and an infection is cleared, come back to have it all done over again. So we want to make sure that they're staying healthy. Also, risk of a DVT. Again, are they supposed to be getting a blood thinner, Lovenox? Many times they are, so we're going to make sure they get that. Are they getting up and moving around? Are they doing exercises like they should? Are we assessing neurovascular status? And then a pulmonary embolism, again, are they having shortness of breath? Are they having tachycardia? Other signs that they're not getting adequate oxygenation. How long will they be there? Usually they're with us 2 to 3 days, sometimes 4 days. Again, and they will go home if they're able to have them at home and have home health, but they may go to a rehab facility for another 7 to 10 days to be able to assess for complications and also increase their mobility. How much weight can they put on it? So we'll also have an order that talks about weight bearing. Okay? We know weight bearing, which means they can't put weight on it at all. Most of the time after these patients have surgery, they can put weight on it. But let's say maybe it's somebody who's come back and they took all that hardware out and they don't have any stabilizing joint in there, they may have an order for non-weight bearing, okay? Non-weight bearing means no weight on that extremity. They can set the extremity, they can't rest the extremity on the ground. Again, that's still weight. And they require an assistive device. I have an assistive device bilaterally. Bilaterally means equally supporting both sides of the body, like a walker or crutches. A cane is not bilateral support. A cane is for balance, which means I can put weight on both sides, but I may be a little bit weaker, so I'm using it for balance. Both sides, a walker or crutches, is for weight support, okay, very different. Toe touch weight bearing means that I can rest my toe on the ground, so I can use it for balance, okay? Can put the foot on the ground to balance, but not weight bearing, okay? Requires an assisted device bilaterally. Again, if I can't put full weight on it, then I need something to balance both sides. Partial weight bearing, again, as they're advancing, limited amount of weight. So they may say 50% of the weight or so much weight. The physician will designate that, and they require, again, something bilaterally. Yes.
What is the 10 number sign?
Oh, sorry, 10 pounds.
Oh, okay.
Just meaning that they will specify like how much weight they can put on it. Weight bearing is tolerated, means it's safe to put weight on it, but it still may be painful. And so they're advancing, they may be on that side. Okay? So weight bearing is tolerated, able to bear as much weight as able to within their constraints, pain, mobility, okay? Weight bearing is tolerated, maybe a balance issue. So they may be able to use a cane. And then full weight bearing means they can put full weight on it. So an assisted device may be used for balance, may not need it. So they may be advancing as they move along. Again, like we said, they may not be able to put full weight after one of these surgeries. They may just be partial weight bearing, but our patient is going to need a walker after surgery. Someone that's younger and more mobile, if they had surgery, they may use crutches. For these patients, we're usually a walker. So how to use a walker? We think, who doesn't know how to use a walker? But they got to use it correctly. So they have to keep all 4 points on the ground at the same time. We don't want them to stretch out in front of them and use the back ones and then try to get it ahead of them. It only advances a step ahead of you, okay? So all 4 points on the ground at the same time. The walker handle should be at the wrist level, and that should be at about the hip level, okay? We don't want it so high that they're walking like this or so low that they're bending over. They should be able to stand up. The legs on the walker are adjustable. So PT can adjust that, we can adjust that, but we want that at a level where they're bent and at about hip level where the walker comes to, okay? They will learn to use a walker before they go home. The PT will assess, do they have stairs at their home or things like that, and they'll help them to learn how to use them on stairs. Okay. How to use crutches, okay? Crutches are not your weight on your armpit, okay? You have your brachial plexus nerves under there that can be damaged if we put our weight on it. So the weight of crutches should be on the hands, on the wrists, right? So we have to be in pretty good shape to use crutches. We want them to be 2 finger widths below the armpits. If we have crutches that are too high, our weight on them, we can damage those tissues. So 2 inches or 2 finger widths below the armpits Hand grip should be at wrist level. Again, we want our arms bent slightly. We don't want them too high or too low. Okay? How to use a cane, okay? Handles at the greater plantar, so that the top of the bone here, a crease in the wrist. So again, we want to have our elbow bent slightly and be able to hold that at about the level of the greater trochanter. Hold on the strong side. So what our patients may do if they hold it on the weak side is put their weight on it. And that's what it's meant for, and they're going to fall. It's only meant for balance. So if you can't put full weight on both your extremities, or you aren't able to put your weight on that side, then you should be using something other than a cane. Cane's on the strong side because when it moves with the affected leg to help balance that. Move the weakened leg with that to balance it out, and then we move the strong leg. So hold the cane to the left hand, move it at the same time as moving the affected leg. Okay? Up and down stairs, going upstairs, good leg first, one step at a time, then we walk onto that step with the affected leg as we move the cane. Go downstairs, cane and the injured leg, and then the strong leg. Okay? Other types of assistive devices when our patients go home, we said we want them sitting in an upright position, not too low. They may have elevated toilet seats. If they have problems with mobility, getting that far, have bedside commodes, but really we want them to walk. So an elevated toilet seat may be needed, a shower chair, so that they're not going to slip and fall in the shower if they can't put weight on that extremity. So to be able to sit in the shower. So working with PT, OT, case management, all of them are going to be really coordinated in the care of this patient to make sure that at home they have what they need. They have home health arranged, or if they're going to rehab, they have that arranged too. So like I said, patients may be there 3 to 4 days depending on getting all of those things arranged for them. Okay. Any questions? Okay, guys. Well, then I will see you next week. Yes, just a moment.